Okay, Chair, we're now live.
Thank you. Good afternoon and welcome to the Health and Overview and Scrutiny Panel. I'm Councillor Ian Holder, Chair of the Health Overview Scrutiny Panel. Members of the public are invited to view this meeting online. Those present are requested to keep their microphones on mute and only turn them on when you're called to speak. Members are requested to keep your cameras turned on at all times. Officers and external presenters are requested to turn your cameras on only when you're presenting your reports or answering questions. If you'd like to speak, please write your name and RTS request to speak in the chat function, or usually put your hand up. And I would now like to invite those present to introduce themselves, starting with Councillor Jeffrey.
Hello, I'm Mark Jeffrey. I'm a councillor in.
Thank you. Councillor Arthur Reigate.
Good afternoon, Chairman. I'm Arthur Reigate. I am the representative from East Hants District Council.
Thank you. Councillor Briggs.
Good afternoon, everyone. I'm Anne Briggs, Councillor for Waterlooville and North Stakes for Hampshire County Council and Vice Chair of Hampshire's HOSP.
Thank you.
Thank you.
Councillor Pepper.
Martin Pepper, Gosport Borough Council.
Thank you. Councillor Richardson.
Good afternoon, everybody. I'm Julie Richardson, Haddon Borough Council.
And did I do Councillor Burton?
No, you haven't. Hello, good afternoon. Thank you, Chairman. Good afternoon, everyone. Joanne Burton here representing Farrowborough Council. Thank you.
Thank you. Councillor Heaney has apologised and said he'd be slightly late because he's still teaching, and I've received apologies from Councillor Brian Madrick and Councillor Abdul Qadir. Right. Agenda item 2, declarations of members' interests. Does any member have anything to declare regarding the meeting today? No.
No.
Brilliant. Agenda item 3, minutes of the previous meeting. Do I have a proposer and a seconder to agree the minutes? Thank you. So those agreed? We can move.
Agreed.
Thank you. We'll move on to the first item, the reports. Agenda item 4 from Solent NHS Trust. Andrew Strevens, Chief Executive Officer, will answer questions on the report, and if you can give us a sort of brief update, and then members can ask questions.
Of course, I'll take the report as read. The strategic outline case is currently being drafted. It's coming as draft into our boards beginning of February, with the final version to be signed off at the beginning of March. We continue to do engagement with our communities. The report references an engagement event we held online on the 22nd of November. We're actually holding a meeting with health watchers across Hampshire and the Isle of Wight next week on the 2nd of February, and we have a further in-person engagement event on the afternoon of the 22nd of February. So we are very keen to hear from our populations as to what they think and how they would like to shape a new organisation providing those community and mental health services across Hampshire and the Isle of Wight. And happy to take any questions you may have.
Thank you. Welcome, Graham. Thank you. Do you, just for the record, do you have any interest to declare?
Sorry, I'm late. I was teaching, and then it takes a while to get into Teams.
Yeah.
I'm also probably going to have to leave by about 4:45, so I've got another set of teaching, but I don't know whether the meeting will last that long, so I'll probably just nip out.
That's no problem. Thank you. Didn't see who put their hand up first, but Councillor Briggs, would you like to ask a question first?
Thank you, Chairman. If there'd been somebody here today, well, my question is, how is it going to benefit the residents of Hampshire? We had Ron Shields came to the HASC. There's no business plan put forward. I just really want to know, bringing such a large organisation such as Southern Health in with Solent and the Isle of Wight, how is it going to benefit the residents, especially with mental health and the problems we have at the moment, please?
Yeah, thank you. I think I was also in attendance at the HASP meeting. You referring to the Hampshire HASP meeting? Yeah, no, I was in attendance in that meeting as well. So I think the issue is in terms of the case for change is kind of designed on the basis that actually there's huge variation across Hampshire and the Isle of Wight in terms of the patient outcomes and patient accessibility. And by bringing an organisation together, actually we'll be able to smooth out those differences, and we'll be able to learn from each of the different organisations about what best practice is. There are a number of particular pathways, and I could reference the CAMS pathway, whereby there are too many handoffs between organisations across Hampshire and the Isle of Wight. And again, by bringing everything together, then actually you're going to have a more unified approach, which I think will be beneficial to patients and their carers. And the really key thing is actually that it is going to benefit patients and our populations that we serve. It's got the sign-off also of the ICB, which is very key. And actually we're currently going through a process whereby the ICB is looking at where resources need to be placed over the next 2 years, with a kind of desire to move more into the kind of prevention agenda, which again plays into the kind of Southern Health and Solent approach to community and mental health services. So I've given you a flavour as to some of the benefits, and again, those will come out in terms of the strategic outline case and the full business case, which we will openly share with our populations.
When can we expect that, please?
When can you expect the strategic outline case?
Yeah.
Yeah, so we're looking to sign that off in March, and then we'll be sharing certainly the highlights from that with our populations. They'll be coming through into the various different oversight committees, whether it's Hampshire, Portsmouth, Southampton, or the Isle of Wight, and we're more than happy to come through there and discuss the key benefits and the key issues that have been identified, and includes the kind of community engagement as well. So more than happy to do that at a future meeting. Yes,
would appreciate that. Thank you very much.
Thank you.
Thank you. Councillor Jeffrey.
Thanks, Chair. Yeah, I just wondered when the consultation and community engagement will actually timescales.
So I missed some of that because I think it went on mute. But in terms of engagement, so the engagement's happening all the time. So as I say, we held the first key one, which is a hybrid meeting, which is back in November. We've got a further engagement event on the afternoon of the 22nd of February, and we're looking to do these on a quarterly basis throughout a process before we kind of create that one organisation. We're appearing in the various different oversight committees as well, and we're linking in with lots of different third sector organisations. And I referenced the meeting with Healthwatch across Hampshire and the Isle of Wight, which is next week. So we're more than happy to come to any event where people want to learn more about this.
Brilliant, thank you. Councillor Heaney. Councillor Heaney, you had your hand up, thank you.
I know my microphone keeps going back on again as soon as I switch it on, it goes off again. Yeah, thank you for that. Sorry, I missed the first bit, so I may be asking a question that's already been answered. But there were sort of two elements to this, aren't there, in regard to the consultation? There's obviously the stakeholder engagement. And I see you had one scheduled for February, and I think you said it was going to be on the 22nd of February. Am I assuming that the HOSP members in Portsmouth and elsewhere will be invited to come along to that if they want to, or is it going to be a event where we will all be invited? And then the second stage, I suppose, is when there is a discussion about significant service change, because the HOSPs have a role as consultees effectively in significant service change. So there could be we sort of had two bites of the cherry, I suppose, in one sense, the stakeholder event and then the formal consultation with the HOSPs. We are about to move in a month or two's time, into the election period. I just wonder how that will affect the potential for meetings, particularly of HOSP, because if you're having your business case done in March, I mean, it's getting close to election times. So I wonder how we sort of manage that so that we can still have our say, but also not get tied up with any problems over the election period.
Yeah, no, thank you. I think that there are different elements, and I'll try and answer the different elements. And if I miss anything, then please come back to me. So in terms of the event on the 22nd of February, I believe invitations have gone out. So they have gone out to councillors across Hampshire, the Isle of Wight, Portsmouth and Southampton. If you haven't had an invitation, then please come back to me and I'll make sure you are invited. The event itself is going to be held at St Mary's Football Stadium in Southampton. But my understanding is that those invitations have gone out, but we can follow up afterwards to make sure that you may have received a copy. In relation to service change, we're not proposing to make service changes as part of this in the creation of a new organisation. So this is the first thing in terms of creating a new organisation. Clearly, we'll be working on pathways, and in future there may be service changes, but I know that clearly we would need to go through the appropriate process and have those kind of engagement and consultation exercises as appropriate. But in essence, the first thing, which is the creation of that new organisation, is purely bringing the different members of staff into one unit, which shouldn't have service change. And then in terms of, I think the last question, which was in terms, I think, further, in terms of the kind of council engagement, I would need to learn more from my communication leads. Obviously, we need to respect the requirements, and we need to factor that in. I'm afraid I can't answer that question at the moment. I'd need to go back to my communications leads on that.
Can I just come back on that? Yeah, I wasn't expecting a definitive answer on that, but I just was sort of flagging up that it's coming down the track, so to speak. So we need to think about when we arrange meetings. I also understand the distinction between service change, i.e. if you're changing the way the service is after the organisation is established. But the problem with structural reorganisation, and depending on how big they can have disruptive effects on the way people work, because there is uncertainty about where people are going to be, what their roles are going to be, how they're going to fit in, etc. So there is that element of it, and I wondered to what extent you have thought about that as a potential issue to deal with.
We are in the process of thinking about that, which we need to do in relation to both the strategic outline case and the full business case. So we need to understand the risks, as you say, from moving from where we are now to the creation of a new organisation. And actually, beyond that, because we need to have a post-integration implementation plan as well. So absolutely, we are cognizant of the risks of those. And actually, what we will be doing as part of the engagement exercises is again just talking through the kind of steps we're going to be putting in place to mitigate those risks. So again, I'm more than happy to have a very open dialogue as regards to those.
And can I be greedy and get a third supplementary question in, which is to say the reorganisation of health services into integrated care boards, the integration of services has effectively made the old trust boards redundant as a form of governance, really, if you think about it. But nobody wants to go around sort of filling around with that when there are probably more important upfront things to do. What sort of structure are you proposing? Because you won't be setting up a new trust, will you? It'll be something different. Is that correct?
In terms of the new organisation, it will be a trust. Yeah, it will be a trust, and it will be a foundation trust. So that will still remain. However, I completely take the point you're making in terms of the integrated care board, where actually all organisations are going to be working much more closely together and be aligned. And as part of that, we've got the creation of the 5-year plan, which includes the integrated care partnership plans as well, which I know that officers from the ICB are working with local authorities to help create, and obviously with health organisations as well. And for me, that's a really exciting opportunity because actually, again, it plays into moving more money and resource into prevention and providing care to people closer in the community. So there's lots of things actually that I think this is a really exciting time for those in the health service and hopefully local authorities as well.
Okay, that's fine. Thank you.
Thank you. Councillor Agate.
Thank you, Chair. It's only just a comment that I haven't received anything for February 22nd.
Noted. I know one of my comms leads is watching, listening on the live stream, so I will pick it up with afterwards.
Thank you. Does anyone else have any questions? No? Thank you very much, Andrew.
Okay, thank you very much. Thank you.
Thank
Bye.
You. Bye. Right, so next on to agenda item 5, which is South Central Ambulance Service update, and from Tracy Redmond. Hello, Tracy.
Hello, Chair. Thank you. hopefully you've had a chance to read my report. I will just pick out a few highlights, and there are some subsequent updates since I wrote the report some couple of weeks ago. With regards to our focus continues to be working across the system in an integrated way in order that our patients get the right treatment in the right place at the right time, which we know is often not ED. There are more appropriate places for many of our patients to be dealt with. And you can see there that we continue to reduce our ED conveyance and signpost or convey our patients to more appropriate destinations. Alongside that, we have seen over the past year through to December quite an increase in demand, 999 demand on our service. With regards to performance has been significantly challenged, particularly towards the latter end of the year through December, exacerbated by the challenges with Strep A, which caused a significant increase in demand, albeit thankfully most of that was worried well, which was dealt with in a different way, but nevertheless did cause an increase in demand. I've reported before about the challenges and pressures pretty much for the last 18 months, a heightened state of pressure being at REAP 3 and 4, certainly for the last 8 months or so. As I wrote the report, we reduced from REAP 4 to REAP 3, lower the better in terms of what that means. And then as of 2 days ago, as an organisation, SCAS reduced to REAP 2, which puts us in a moderate state in terms of our current operating position. This is primarily driven by, we have seen a slight drop off in demand, we have seen an increase in workforce availability, and we've seen a significant decrease in hospital delays, which allows us to be much more responsive to the community. Just in terms of hospital delays, as I say, there is a significant impact on our ability to get to patients in the community when the ambulances are delayed offloading at hospital. We do continue to work with Portsmouth Hospitals Trust and the wider system in addressing this. And actually, since the report, the difference of a few weeks, we're in a significantly better position than we have been actually for many years. And have sustained it for longer. We've seen ebbs and flows. We've seen good days that have lasted, good runs that have lasted 3, 4, 5 days. We're now into week 3 of good performance in terms of hospital delays, which knocks on to good performance in terms of us being able to deliver our care. In January, we're averaging 26 hours a day being lost at hospital. Most of that in the first week. Last couple of weeks, we've been 2 or 3 hours a day being lost, which is often due to complex clinical issues rather than any other reason. Whereas December, we were averaging 128 hours per day being lost. So some significant change there, which really does have a knock-on impact on how we can respond to patients. And alongside that, we have got a SCAS-wide improvement plan in process at the moment, driven by a number of things, including the CQC report. And as you would expect, we are focused very much on patient safety, patient experience, and our staff and how we look after our staff as well. And we can't deliver our care without our staff. So the 2 main focuses are patients and our staff. It feels fragile at the moment. I think we're in an early state of recovery. So now we're pushing to make the current position the new normality across the system for everybody to be able to provide better patient care. And we're just collectively in the process now of working how we can get from working in a mode of crisis, which we've done for many months, to making that normal going forward and being able to sustain that. That's kind of where we are now.
Thank you, Tracy. The improvement in handover delays at the hospitals, what's that down to? Is that purely staff availability, or has there been any process changes? Anything happened at the hospitals that facilitated that?
Yeah, there's been an awful lot that's gone on. There's been an awful lot of focus on discharges, earlier discharges. The hospital occupancy is a significant factor. Obviously, the bottom line is the hospital's been full, and therefore physically we can't get in the front door. So there's been a lot of focus on across the system with partners on discharges and improving that process. There's been some focus on flow and escalation within the hospital, and escalation areas that have been opened within the hospital at times of surge. So it's not really one thing. I think it's a combination of various things, along with a reduction from us in patients going into ED as well. Kind of all of it combined together has come up with some good results.
Thank you. Councillor Richardson. You're on mute.
Sorry. I wondered if you could give us an update on strike action and how that's impacting on delivery of service as well.
I can. So we have had a number of strike days. So primarily within SCAS, the unions are GMB, Unite and Unison. And we do have some nurses who work in SCAS who are in the RCN union. The GMB union is primarily patient transport services in our Surrey and Sussex area. So in terms of impact for our patch, we've not seen any detrimental impact there. And the RCN have not yet striked within SCAS. And we're still awaiting the outcome of the Unite and Unison ballot, which is a significant proportion of our staff. But we have got plans in place to mitigate that, should that happen.
Thank you.
Thank you. Councillor Agate.
Thank you, Chairman. Tracy, what's the effect on your operation, the groundwork being carried out on the new emergency department at QA? Is that causing you any problems?
No, none at all at the moment. And we have been involved in the design of the new ED as well. So we're very much looking forward to that over the next few years developing, but there's no impact currently for us.
Next question. I see UTC Petersfield are improving access and times on their facilities. Is that helping?
We do. I don't know actually in terms of data, but we do regularly review access times of different alternatives to ED and other patient pathways. And we introduce new pathways as and when we can, and review times of day based on demand and those kind of things. Petersfield in particular, I don't know if there's any. We don't take many people there, to be honest, so I would imagine the impact would be minimal, because most of the patients that go there are walk-in patients rather than ambulances.
Yeah, sorry, I asked because I understand that X-ray are doing longer hours and increase the facility available. Thank you.
Thank you. Councillor Heaney.
Thank you, Chair. I was a bit intrigued by the two graphs on page 14 about the conveyance decrease, demand increase, but also the figure at the bottom of the comments about SCAS's target, or the national target. It says that the SCAS continue to convey consistently less than the national target of 49% of its incoming 9/9 demand to the emergency department. On first reading, that sounds like potentially a good thing. You know, target seems like something you ought to be doing, but if we're conveying less people to ED, that might be a good thing in the current circumstances. They don't need to be there. So I just wonder what that 49% target is really about, whether it's an average or, you know, it doesn't quite seem to make sense to me. And I think being under it might be a good thing, but the message isn't always clear in that sense. The second thing was looking at your ED conveyance. That, if I read it correctly, is the number of times you take, or the people you take to ED. the percentage of the trips you take to ED, it's only 42%, so around about 60% does other things. But the overall demand increase is high. But that demand, is that all emergency demand, or is that increased demand in other areas as well? Does that make sense?
So, yeah, absolutely. So the demand showing here is 999. So it's incoming 999 calls from this geographical area, which, as described there, has been on the increase over the last year. And the 49% lower is good on the 49%. We aim to not have ED as the default destination. As I said previously, there are many other places that are better suited for example, frail elderly patients can often be better cared for in their own home in the community, and we're very much linked into the community teams now. So we might go out as a 999 call and then refer those patients onto the community teams for onward care rather than take them into ED.
So that means that you just wouldn't complete the visit, if you like, till they go back on the road and then they'd be available for something else afterwards. That's how it would work. Yeah. Okay.
Yep.
Okay. Well, yeah, that's obviously good. Do you have enough ambulances? I mean, you have this issue with obviously people being held up at hospitals waiting for the gun, but do you have enough ambulances to do what you need to do, or do you have enough crews to do what you need to do? Is there any flexibility within the workforce to be able to either increase or make available more ambulances or more crews?
We do have enough ambulances. Crews recruitment and retention is a challenge because there are many opportunities now for paramedics that there never used to be. For example, working in primary care, working indoors in the warm from 9 to 5. And get paid the same money. So there are benefits of and our clinicians, as they're registered paramedics, are able to now move around in healthcare, which they never used to be able to do. So that creates a recruitment and retention challenge. We do have an escalation process whereby should we need extra clinicians on the road at times of surge, then there's a process of clinical managers who are qualified paramedics who are able to then stop their day job and go out to patients should they need to. And the higher we escalate, the more of those managers will come on board. Obviously, there is a limit.
Yeah, I see. One of my colleagues says when you complain about being an academic, you get the reply that well, at least it's not outdoors and there's no heavy lifting involved.
When I start going out to patients, then we know it's gone a little bit wrong.
Thank you. Councillor Pepper.
Yeah, thanks, Chair. In terms of the hours lost, I keep looking over to my right because I'm looking at my other screen. What does that mean in terms of percentage hours lost? And can we contrast that and compare that? We're talking about the staffing shortages. Can we contrast and compare that with the hours lost because we cannot recruit, presumably to the level that you're able to recruit or your establishment? I'm happy to try and repeat the question if that doesn't make a lot of sense.
It does. I'll try. Have I got that as a percentage? No, but I can do those sums and get back to you.
It sounds a lot, but I don't know if that's 2% or 20% or 50% or whatever.
It's an awful lot. It's probably 20 times, and I'm saying this off the top of my head without looking at the numbers, it'll be probably 20 times higher than the next worst hospital in the region. It's a significant outlier, and nationally, Portsmouth Hospital has been a significant outlier with ambulance handover delays, and I know we've spoken on this forum many times about it, hence why we're quite excited that we're in a more sustained, better position at the moment now. Yeah. But it is significant in terms of impact.
And in
So
terms, so you're going to provide, would you be able to provide those figures? I don't want to spend half of your staff creating these figures, but do you have that? Would you have them reasonably readily available?
I would have to work them out because we don't report anything like that as a percentage. We report it as hours lost. So that's the number of hours that the ambulance should be out looking after other people and is sitting on the forecourt outside the ED department.
Yeah. It's just that you've got so many staff and they work 8 hours a day or whatever it is. So therefore you've got staff times 8 equals minus that. Anyway, I'll leave you to think that through. But in the same way, there are staff shortages, my words, not yours, and therefore that would reduce the number of hours against your establishment. And now I'm trying to contrast and compare the delays that are inbuilt into the system, if you like.
Yeah, I mean, we have got staff shortages. We are able to, at the moment, meet our short-term forecasted demand with the staff that we've got. We struggled through the back end of last year due to more around staff sickness rather than staff shortage, with flu, parents looking after poorly children and things with the strep A. So it was more around staff sickness. I mean, the recruitment retention is a bigger, longer term thing, and we're lucky here because our paramedics go through Portsmouth University, a lot of them, so they're quite a good feeder for us locally in terms of staff compared to some other areas of SCAS. So there is an impact with staffing, probably on a day-to-day basis, more around sickness, which has improved now, hence one of the reasons why we've seen our improvement in performance.
Okay, thank you.
Thank you. Councillor Briggs.
Thank you, Chairman. Hello, Tracy. Underneath your patient safety and experience, have all the safeguarding issues that you had earlier this year been sorted?
That has certainly been a major focus. There has been a significant investment in leadership of that team because the team was very small previously, which was one of the challenges. And there is a significant improvement plan in place. Most of the things have been addressed. I think there are some things that continue to be a work in progress, and we're working closely with the CQC on that because it was raised by the CQC previously.
Thank you. May I ask another question, Chairman? Thank you.
Yes, of course.
The most complaints, everybody appreciates what you do and everybody appreciates the stress and how hard you all work. But the most complaints as a councillor I get is 111. And I know you're encouraging everybody to go online to get through to you, but people of 86, 87 can't. And I also understand you have to have a set number of questions. But when somebody is ringing up and they state that the person they're ringing for has Parkinson's, they've been in hospital with fractures to their spine due to their condition. And then when somebody says, and I've got a recording of this because I just happened to be visiting these people, they'd asked to see me. And when they finally get through to 111 and they explain about the condition of the person, but the husband says she's going in and out, she can't really speak. Well, she could speak, but everything was at a distance. So the person on 111 went through, I know there's a standard set of questions, but to ask somebody who's got Parkinson's and fractures in her spine, if she's been deep sea diving, in the end, she was virtually in tears, asking her husband to ring off. And then after half an hour, a clinician was put online. And when I think about it now, you can smile about it, but it's ludicrous. And I just don't know. And then when I'm having my moan, somebody else who had a bad eye, their 111 didn't know how to answer because it was my area, which is Waterlooville. And in the end, they sent them to St Mary's, to the UTC, but they don't have an ophthalmic division there. The person they saw didn't know how to work the machine. There seems to be some improvement or in the way the questions are answered. I mean, the urgent treatment centres are fine, but it's no good somebody going down there for 2 hours and then when they get in there, no one can help them. So I don't know how you can improve on that because some of the questions are quite ludicrous.
Yeah, and I don't disagree with your deep sea diving example. The questions are set nationally from the national 111 team, so it is difficult for us to influence that, although we do have representative on the national group. And the call takers are not clinicians, so whilst it feels probably like too many and potentially irrelevant questions, 111 does err on the side of caution in terms of safety to get as much detail as possible. But I do appreciate the examples that you cited are less than ideal. It's difficult to comment on the individual cases clearly because I've not looked into them. But the questions themselves are set by the national team.
So how does one get to tell them that it's just so frustrating? People know there has to be safeguarding, and if you just speak to the call centre person who's reading from a script and then they have to go and find a clinician which goes all through it again, how do we get to speak to someone to say that that's in the end when people hang up and go down to A&E or AD? I know it's, but how do we get them to realise it's not always working for people?
I mean, I guess that's probably, I don't know the official route, but I would imagine there must be a route through NHS England to provide feedback on the 111, because as I say, it is a national service in effect. There must be a way. I don't know the answer, I'm afraid. There must be a way to feedback through NHS England, I would imagine.
Okay, thank you, Tracy.
Thank you. Councillor Richardson, did you have a question? You're on mute.
Sorry, keep forgetting, Chair. Tracy, is there a report from 111 that can be included in your reports? And also another question is there an element of discretion that a call taker can use? Just thinking about the previous question. You know, as a nurse myself, if I was asked questions, I would sort of think maybe I could jump a few questions. Is there something in the system that allows the caller to use that discretion?
No, because the call takers are not clinicians.
Right, so they have to.
So
they're duty bound to do that.
Yeah.
Okay. And is there a way then that when that can be explained to people calling in? You know, I'm sorry, some of these may sound irrelevant, but we have to ask them.
Potentially, yeah. I could certainly feed that back into the 111 service.
Yeah, because there's always an element of distress when someone is ringing up, and as Councillor Briggs was saying, you know, someone is poorly, they don't understand the system. You know, if the caller just sort of expresses some sort of empathy with the caller and say, you know, I have to do this, is there a way to feed that back to 111?
Yep, I can do that.
Thank you.
Thank you. Councillor Pepper.
Thanks, Chair. Yeah, sorry to bother you again on this. Just a personal experience. I was ill sometime last year, and I was sent by hospital to QA Portsmouth. I was told by the ambulance staff that had I been sent to Southampton, for example, I would have been dealt with much more quickly. But there was I wasn't feeling well at the time, surprisingly. I didn't really understand the subtleties of the conversation we were having, but he said he wasn't allowed to take me to Southampton because the handler wouldn't direct you in that sense. I didn't get the full detail, but it seems to me that a full hospital is a full hospital. Best go to somewhere that isn't quite so full.
Yes, and we continue to work across the ICB with the other hospitals. We do divert to other hospitals, sometimes in times of crisis, but it has to be agreed by both hospitals, in particular the receiving hospital. And for example, Southampton is often in as challenged a position inside the hospital, albeit they don't queue ambulances because they queue in their corridors inside. So whilst you may have got off the ambulance a bit quicker, there's no guarantee that anything thereafter would have been any quicker. In terms of where the ambulance crew go, they will go to the nearest, most appropriate hospital for the patient's condition.
Thank you.
Thank you. Any more questions for anyone? No. Thank you, Tracy. Thank you for taking time to come and talk to us.
Thank you.
We'll move on to agenda item 6, which is public health update from Helen Atkinson. Helen, do you want to give a brief overview?
Thank you, Councillor Holden. I think the slides I'll take as read. There's quite a lot of them, but basically an overview of what we are prioritising in terms of our business planning for this year. I wanted to mention all of this work sits within how we are working across the system. So very much, and hopefully you'll see that included in the slides, which are very high level. We are working very closely because I'm a joint director, part of Health and Care Portsmouth, so we're very closely with our colleagues in the council in adults and children's services, but other parts of the council like housing and regeneration as well. But we also work very closely across the whole of the system of Hampshire and Isle of Wight, Southampton and Portsmouth in the Integrated Care Board. There's 3 directors of public health across the system, one for Southampton, one for Portsmouth, and one that works across Hampshire and the Isle of Wight. And we work together as we have a system leadership approach where we work together to feed into a lot of the work in the Integrated Care Board. And we've been very much a part of working towards the interim Integrated Care Partnership Strategy, which was published just before Christmas. So a lot of the work we do is obviously focused around health prevention and tackling health inequalities. And we deliver our business plan by ensuring that what we prioritise is both within the local Health and Care Portsmouth at Place partnership plan, and we've been very much part of feeding into the NHS operating plan this year. To ensure that we, showing that we're working really jointly together, but also then working at system as well. And we also work quite closely regionally. There is a regional association of directors of public health. So a lot of the work we do across the region, working closely with NHS England as well. So that was all I was going to say, really. It's just to say this is our business plan. A lot of it you'll recognise because a lot of it doesn't change. The big change this year, I would say, there's and I know it's an area that people have been interested, council has been interested in the past. There is additional funding this year that has come in for substance misuse, and we've had to work. So we've worked both regionally across Hampshire and Isle of Wight ICB, as well as setting up a local combating drugs partnership. So there's one per authority in Hampshire and Isle of Wight, and then we work with the PCC's office. Police Crime Commissioner, Police and Crime Commissioner, who has an overarching Hampshire and Isle of Wight group where we report into. But that has been additional funding across 3 areas, which you'll have seen in the slides. So it's a partnership approach. It's not just public health leading. I'm the SRO and the chair because of the fact that the majority of the additional funding that's coming comes via public health. But it's a 3-pronged strategy, so very much focusing with the police leading on disrupting the drug, I suppose, things like trying to disrupt people being able to access drugs, county lines, etc. Then there's a big focus on improving treatment outcomes, and a lot also about trying to which you see again in the mental health agenda, which is ensuring that the health there's better health outcomes for those that are substance misusing. So particularly you'll be aware that we have a big homeless population in Portsmouth who have a high instance of substance misuse. So it's a lot about trying to ensure that we're improving the health outcomes of our homeless population as well, particularly around substance misuse, and connecting into mental health as well, because you rarely see just substance misuse. So that's a big focus of the work. And the final bit is working with children around young people and preventing substance misuse take up from children and young people. And then the other areas of work, because obviously in the past talked very much about COVID, we are not over COVID, but we are very much living with COVID now. So we've had a lot of focus in the last few months on supporting, working alongside our adult social care, children's colleagues, but the NHS around winter management, much as we've just talked about through the ambulance service. So we've had a big focus on supporting. Obviously, there's been a big increase in seasonal flu and vaccination uptake, but we've had a lot of leadership locally around supporting schools and the NHS on the strep A outbreak as well. And then the final bit, which I think we're very proud of in Portsmouth as a council, it's a corporate, well, there's two bits actually, corporate role is our cost of living work in Portsmouth. So we've set up a cost of living hub and can share, we've got quite a lot of data now. It's been running for a couple of months, and we have hosted within our team, we have a specialist worker who supports. So when people call into the hub, which is managed by our call centre, and there are people who have greater need or quite complex situations where they need more intensive support, they come through to a specialist worker in public health who supports that individual. And we've had 26 in the last 5 or 6 weeks, people that have been supported, of which 17 now have been supported, and there's still currently 9 cases where that person is supported to get the right help that they need. And of course, it's very complex, the cost of living crisis. So that could be support on fuel and energy, food, etc., or just actually how to access different services. So we work as the kind of conduit into other support services within the council and partners. And then another bit of work that we're more involved in this year is the climate change agenda, which we work across with our colleagues in housing and regeneration. So really a big focus on greening. So we host the Portsmouth greening post, where we're trying to ensure we bid quite successfully for as much additional funding as we can to basically plant trees, which improves the environment, improves mental health, emotional well-being, but also, most importantly, has a positive impact on air quality, which you know is a key priority in the council. So that's a kind of an overview. Happy to take questions.
Thank you, Helen. Does anyone have any questions on the report? Councillor Richardson. You're on mute.
So sorry, I keep forgetting. Thank you, Chair. Helen, I just wondered, could you just talk me through a little bit about the sexual health bit? Because it's quite interesting to see that things have worsened there. And I just wondered, is that anything to do with not being able to access GP services as well these days? You know, for some people it's more difficult. I just wondered if you could give me, you know, some of the facts behind that and why you think these have worsened.
I think sexual health is no different than what we've seen in terms of quite a lot of our, I suppose, what we would call our prevalence data worsening. So what we have seen through the COVID pandemic, and so it's not just one thing, it's quite a few things that are complex. I think it's fair to say people particularly through lockdown, people risk-taking behaviours increased. So we saw people eating more unhealthily, drinking more, drug taking, and that included obviously sexual health as well. So we saw an increase in STIs. Much like we've seen an increase, unfortunately, in hazardous levels of, of drinking in hazardous levels. And the only thing that we did see at the beginning of the pandemic, which did make an improvement, was people moving more. So people took more physical activity, but that unfortunately deteriorated through the pandemic as well. So if you look at all of what we would call our main data, unfortunately, everything worsened, obesity, but the sexual health, I think, is a combination of people's I think you often find in situations like a pandemic where people are perhaps mental health and emotional well-being is impacted, that people's risk-taking behaviour increases. So there was a bit of that. There was also no doubt that people struggled to access. So our sexual health services, much like most services in the NHS, because it is an NHS service, it's Solent that provide that service. Access changed to online, and obviously I think it's fair to say Solent did really, really well in trying to ensure that people were accessing services, whether remotely and still face to face. So it's not just primary care, because we have, although we do have contracts for things like long-acting, LARC, which is long-acting reversible contraception. Through GPs, you can also access those services through community pharmacies and directly through sexual health services. So I think there's a combination of pandemic, services changing how they delivered, and also people not necessarily knowing or people stopped accessing services because there was a view that there was a risk if you went into NHS services. I think people stopped accessing services. So all of that has come together. The one thing I would say, interestingly, was actually having a high rate of testing isn't necessarily a bad thing. So we've got, from the data, you'll see that we have the highest rate. Now, that both means that we've got a high rate of risk-taking behaviour, so people are accessing. But the more people that test, the more you're identifying cases early and treating them. And of course, we've had other outbreaks during the pandemic, like we've had the monkeypox issue, which was mainly related to sexual transmission. So lots of other things have happened. Big focus. So although it does look like it's got worse, I think also we have adapted, and the service has adapted to offering services in a more easy or straightforward way. So you can actually now test by post, which might seem a bit strange, but you can basically take an HIV or an STI screen, and you can request it, take the test, and then send it off and get your results. So you never actually have to see, unless you're obviously called in because you're positive, you don't actually need to see the clinician. We've got a big focus this year on working with the naval base in particular, because we have a high rate of STI in parts of the city where we think it is also related to naval personnel. Which I'm trying not to say anything that's going to be reputation damaging, but they are generally a young, active workforce that travel around the world. And so we're doing a big focus on HIV testing, because they're quite a high risk workforce, because they do travel around the world into high risk areas. So what we're trying to do is work much more closely with the naval base around both our STI outbreaks, but also about encouraging testing, because in the past, personnel in the military, so that's all, it's Navy, Air Force and Army, have not necessarily had high testing rates. So lots of work going on there with the Terence Higgins Trust. So lots of positives, as well as the fact that we are worried about our STI levels and also our teenage pregnancy levels.
Yeah.
That's increased as well.
Mm. Thank you very much, Helen. Thank you, Chair.
Thank you. Councillor Agate.
Thank you, Chairman. Yes, Portsmouth Naval Base and the Navy's drug squad brings back memories of 30 years ago when my daughters were at school in Portsmouth, and that drug squad frightened the living daylights out of the pair of them. So they've never been touching drugs ever since. One of the questions, what I was expecting at this meeting, I don't know how much you're involved with the Community Independence Service.
Is that the adult social care independence team?
Well, it comes under Health and Care Portsmouth partnership, according to the minutes we had.
And we're all part of Healthcare Portsmouth. I think it
Sure.
might be the Adult Social Care Cancer Independence Team.
Yeah, we're expecting a report from them regarding the decommissioning of CIS.
I'm afraid I think that might have to go to Andy Biddle as a request. Doesn't come under me. However, I would like to say that post-COVID now, because obviously we were very focused during that period of time, we are looking at all of what we would call our working directly with communities and individuals. So between us, if we take Health and Care Portsmouth, we've got a wellbeing service where we obviously support people to stop smoking, drink sensibly, move more, and also mental health and emotional wellbeing. Adults have got an independence team, which is where they're working with, obviously, not all just older residents, but also with those with physical disabilities to actually basically be more independent. So some of that connects into what we do, because obviously a lot of what we do is the preventative bit of keeping people healthy and well. There's also the primary care networks have social prescribers, and we've just taken on the Health Champions team as well, which we set up jointly across Health and Social Care Portsmouth to work through COVID to support people finding out the information they needed, but also keeping people working with communities. So Health Champions are volunteers from our communities who we work with getting key messages and social media to encourage people to take up vaccination and other opportunities. So we're trying to look at how can we bring some of those teams to work more closely together to support our most deprived communities. So I'm afraid that I've now kind of just ad-libbed, but that team doesn't come under me. But we are looking to how Andy, myself, and Joe York in the obviously in ICB Portsmouth are looking at how we can bring some of those functions more closely together. But I can't answer that question, I'm afraid, Councillor.
Okay, thank you, Chairman. Can I just make the point that we were led to believe that we would receive a report regarding Community Independent Service in Portsmouth in a minute at our last meeting in December.
Yeah, I'll chase that up.
And the other thing was that the amount of resignations that they reported regarding specialists, we've not seen anything about that either.
Okay, no problem.
That's on page 33.
I'll find out. Thank you. Councillor Briggs.
Thank you, Chairman. Helen, underneath the partnership working children's public health, do you have a team that goes in when children are on the edge of care to stop them from going into care?
So, Councillor Briggs, it's fair to say that much as it is with adults, there are many teams that work together around children's services. The function you're actually talking about sits within early help within the children's directorate under Sarah Daly. So our responsibility in terms of public health, we fund, so through the public health grant comes the funding for commissioning 0 to 19 services. So that's the health visitors and school nurses. And in Portsmouth, we've made the decision to pool our funding. So we have a Section 75 legal agreement between public health, Children's Directorate, so that's the social services team, and the provider of the 0 to 9, well, of all children's services, which is Solent NHS for us in Portsmouth. So we have a joint commit. So we pull the budget to deliver what we call early help. There is a team within early help. I'm afraid I'm not the expert on that. That sits within Sarah Daly's social care team, which will be staff from both the NHS and social care who do go in and support children on the edge of care. They also prioritise. We have a prioritisation process in Portsmouth where we are targeting the children most in need to try to prevent all the way along the need for greater services. So it's a preventative model, early help, as it says. And where our part comes in, so we lead what's called the public health children's strategy, that slide has the 4 areas that we look at. So it's very much on the health improvement bit. So we work closely with maternity services, children's services and Solent to try to, with a main focus on trying to get women to have the healthiest pregnancy they can. So stop smoking, eating sensibly, all of those. So it's that kind of pre-birth, but also working then with families around trying to encourage them not to smoke in cars in front of children. So it's the kind of preventative stuff, what we call primary prevention, around smoking, alcohol, healthy eating. We also worked with children's services around good parenting, which I suppose comes into the bit, but it's all connected. So the bit that we focus on is what we would call the primary prevention, which is substance misuse, tobacco, alcohol, healthy eating. It's all the bits that basically are what we call the underlying causes of why people get ill earlier and have a need for care and die early. So, but we focus that on children. We also find that working with children is a very good opportunity to influence families. So if you can get children to take those messages and those healthier lifestyles, they can take them back into the family. So that's our bit of it. The bit you're talking about, unfortunately, does sit with Sarah. And I don't know enough about it, but I know they do some really good work.
Okay, thank you very much.
Thank you. Councillor Jeffrey.
Yes, thanks, Chair. Helen, I just wondered, do you have any involvement with the City Council's work with the university to get them medical school set up? Or is that something entirely not your area?
Actually, I am involved, and that's because I've got an interest in that area. It's not one of our strategy, but I'm actually sitting on the partnership board of the medical school bid, which is going really well. So I am involved in it, and also when it is set up, we will be part of the trying to support the educational supervision training. So we are, as a team, we are an education and learning team, an education team. So we already have, I have 3 consultants in public health, all educational supervisors. They're qualified educational supervisors. So we already have quite a lot of trainees in the team, which are a great benefit. You obviously have to put time in. I know Councillor Heaney will be very familiar. You have to put time into students, but you actually get some really good outcomes. So they do quite a lot of our work with us. So at the moment, just to give you an example, we have for every quarter we get 3 new F2 doctors who are doing their GP training placements. So they're part of they usually come straight to us from either acute medical or A&E, or straight to us. And they do 3 days or 2 days with us and 3 days doing their GP placements. We've also got currently 2 what we call specialist trainees in public health who are training to become consultants in public health. And we have 2 joining us this month, actually in February, are 2 GP specialist trainees. So they're doctors already trained to become GPs. And we will have 2 health psychologists from the university joining us. That's new for us. So you can see between us, quite a small team, we have quite a lot of educational supervision already, and we have been asked to take part in the educational support training of the GPs, because I'm talking very positive, because as far as I'm concerned, it's going to go ahead, and we're already planning the course. So we're part of the setting the coursework, because what we want to do, because as you'll be very familiar with, I'm sure if you haven't had a presentation, I would really recommend getting a presentation from the team, because they are so proactive and so positive. And this is unlike other medical schools in that it will be a community-based training program. And what we're most excited about in the council is that it will be training. That Portsmouth and South East Hampshire, so it's not just a Portsmouth, we've got we have a real workforce crisis in many areas in the NHS, but particularly in dentists and GPs. So this is going to be training the GPs that we need. And there's quite a lot of evidence if you train locally that people will stay locally, particularly in the first years. So I'm very excited that we are training the future GPs, and so they will all be doing community projects. So we've agreed that we will host those GPs trainees on community projects around things like that we work on, like substance misuse, sexual health, etc. So I'm very excited about that, and also very excited because I'm working currently also around with the Dental Academy with Professor Chris Luca as well, about looking for opportunities where we can be training more dentists locally. So the idea, and that's much earlier stage of discussion. The medical school is much more advanced because I think we're already at stage 3 or 4 in the medical school, but we're looking at the and you'll remember there's been a GP summit, but there's also a dental summit last year that Penny Mordaunt hosted. So we're looking at all of the opportunities, how we can increase all health promotion, and we're working with Solent and the Dental Academy on that, and that's happening now. So we're increasing how much we can work with schools, care homes and our homeless population, but also lots of discussion about how we can increase the training opportunities, things like a centre for dental development in, those discussions are underway to see how we can actually train. And it's not just training dentists and GPs, because as you know, we will say, and I'm sure Jo has said it many times if she's come to talk to you, it's that whole workforce. So it's primary care isn't just GPs, it's specialist nurses, it's pharmacists working in primary care. It's a whole team approach. And in dental, it's exactly the same. It's the dentists, it's the dental technicians, the dental nurses, dental therapists. So we're working with ICB Portsmouth, or Health and Care Portsmouth, and Solent and the University Dental Academy, how we can increase training options. So all of that work's really exciting, I think, because I think it's about us wanting. We can't change all of the national policy, which is because this isn't just a local issue, this workforce crisis, it's a national. We can't change all of the national policy, but what we can do is do what we can for Portsmouth, and these are local place-based projects to improve access, not just to Portsmouth, but Isle of Wight and South East Hampshire. Sorry, you can see I get quite excited about this work. So yes, I am involved.
Thank you. How's the medical school plans going with the university? Is that?
I think they're going well. So as I understand it, we're at stage. I say we because it's all part. We're all partners in this. I think they're at stage 4, which is quite well progressed, and they're hoping to be. And I really would, if you haven't had a. I don't know actually if I don't know if it's appropriate. Huge apologies, Chair, if it's not appropriate, Councillor Holder. But actually, if you get the leads, they give a really good update. And I think we are looking currently, if each stage goes ahead, to be able to take students. I think, and I'm looking. I don't know if Councillor Heaney knows anymore. I think it's from 2024, so it's not this year. And I think it might be if everything goes ahead from next year. I think that's right. But it's if you get the chance, because they do quite a lot of open events where they go and present, they are talking about it. I can let Councillor Holder and Lisa know if there's something coming up where they're doing a presentation. But they came to the Health and Wellbeing Board 2 meetings ago and will probably be coming again. So I can mention that if you want to, because I think you can easily, because it's open to anybody attending.
Yeah, I think that'd be good if you could let us know.
Yeah.
Thank you, Helen.
Thank you. Any other questions for Helen? No. Thank you, Helen.
Thank you.
Thank you. And the last item on the agenda is dates for future meetings. I think you've all got on the back of the agenda, the panel are asked to agree proposed dates for future meetings. I think 22nd of June, 21st of September, 23rd of November, 23rd of January and 14th of March next year. All at 1:30. Is panel happy with that? Yeah, should we say those are agreed?
With any luck, I might be voted back in again. So we should look forward to this.
Hopefully we'll all be back. And thank you. I think that's the end of today's meeting. Next meeting will be on 16th of March at 2 o'clock. If I could ask you all to stay on camera until we get the okay from Lisa that the live stream's off. Lisa, thank you.
Okay, I'll just go and stop it. Thank you.